So hello students. So today we're going to talk a little bit about inhalation agent, neuromuscular blocking agents, and the maintenance phase of anesthesia. Now, before anesthesia, the world was a pretty brutal place, I guess much like how it is right now. But in terms of surgery, you couldn't do surgery on anybody. If anybody had a surgical pathology, they more or less would either have to suffer through an awake surgery or just bear the pain and die. And most surgeons probably weren't that good because they could only operate for short periods of time. Now, the first modern day anesthetic was the drug known as ether. Ether was used in the US and chloroform in the UK. And this was one of the first public demonstrations in 1846, so not long ago. And this really was the start of modern medicine. And this was developed by a guy called William J. Mortimer. And Mortimer was a dentist and he developed this drug, ether. And this is a very successful demonstration. It's the famous ether dome demonstration. And this was done in Massachusetts General Hospital. And this is the excising a tumor from a patient's neck using ether. Now, Morton was a guy who discovered the anesthetic, and he became very successful because his dental practice was the only practice where you could get a painless extraction. So he became very rich of this discovery of anesthetics. Now, subsequent to which, there were further developments followed by the use of local anesthetics, like, for example, cocaine, which is one of the first local anesthetics, and then it subsequently developed your modern day anesthetics like lidocaine, bupivacaine. Now, these drugs, a lot of these drugs were initially started in for dental practice, for toothache, which was a common discomfort experience without effective analgesics at that time. Now, modern day anesthesia, it's all about patient safety, right? If you all had responded to that discussion activity, you would have seen that by and large, nobody wants any complication after during surgery. Nobody wants to die. Everybody wants the complication rate to be as low as possible. That's why everything we do as anesthesiologists must give the patient a certain amount of guarantee that they're going to have a good outcome. That's why there's so much invested into safe drugs, equipment, and all these sorts of things. So a modern day anesthetic setup is very different from the previous setup that you would see during the ether day with just a patient with some chloroform. We have to monitor the patient because the patient would expect nothing less. Yeah, so modern day anesthesia is very safe. Now, there are different phases of anesthesia. We talked about the induction phase in a prior video. Now we're going to talk about the maintenance phase and the emergence phase. Now, the key thing to understand when talking about the maintenance phase is the anesthesia triad, and that's what we need to pay attention to. So it's important that we have an understanding of this. So the anesthesia triad is hypnosis, analgesia, and muscle relaxation. So hypnosis is essentially the process of keeping the patient asleep. And we do this by giving the patient inhalation agents and IV agents constantly. Then there's the other part, which is analgesia. Now, truthfully, a patient will not feel pain if they are under anesthesia, but the body still has a response to pain, and we call this a noxious response or a nociceptive response. The other part of the triad is muscle relaxation. Now, not all cases require muscle relaxation, but abdominal surgery during intubation, we need relaxation of the muscles. And I'll talk about this a little bit later on. So a modern day anesthetic is a very customized thing to each patient, and we tend to tackle each of the individual components. So regarding maintenance, we can maintain anesthesia given either IV drugs or inhalational drugs. Inhalation is the most common used form of anesthetic maintenance. And we commonly do this inhalation anesthesia via what we call volatile anesthetic agents. Volatile because they are liquid and they vaporize very easily. And these agents are administered by a device called a vaporizer. And that's a pretty complicated device. You really don't need to know too much about that. It's given via a vaporizer. So the funny thing about these agents, or the interesting thing about these agents, is that they are introduced via the breathing circuit to the patient. And as opposed to normal drugs, which hit the circulation, these drugs work via the lung. So they goes into the lung, and then from the lung to the blood, and then eventually to the brain where they work. So you have to be breathing for these drugs to work. And all these anesthetic agents, these inhaled anesthetic, the brain is a site of action. Now, an important point to note is that when we give any anesthetic, supplemental oxygen must be given. And it's usually given throughout all general anesthetics. And the reason for this being is that the drugs that we give do suppress the ventilation. They develop basal atelectasis when the patient goes supine, and this could result in VQ mismatch and a shunt. Head down positioning, as required for a lot of procedures, could cause collapse of the airways. And a lot of the compensatory mechanisms, such as the hypoxic pulmonary vasoconstriction, is lost. The fraction of oxygen could be as high as 100% to as low as 0.3%, but it always generally is more than 0.3%. Now, some more specifics on the inhalation agents. They're really halogenated ethers, and what you'll see a couple agents being commonly used, and that is isoflurane or sevoflurane. Sevoflurane is the most commonly used agent. And again, like propofol in the last video, what we talked about, sevoflurane, the superiority of sevoflurane is unparalleled. That is more costly than all the other agents, commonly isoflurane, but its versatility and its superiority is really unmatched. So that is the most common drug you will be seeing used. Now you may be wondering, how could breathing in a gas allow somebody to not feel pain while still literally being alive? So it's really a mystery how these agents work. And if you think about it, you'll understand. And the mechanism has never been confirmed. There are different mechanisms. Some is that they dissolve via the cell membranes in the brain to act on the cells itself. There's a GABA-related effect, and something it reduces transmission in the spinal neurons. Now, a little bit about pharmacokinetics. So don't get worried now. I'm just doing this that you all need to have a basic knowledge. So pharmacokinetics is really how the body affects the drug. Now, we're not giving these agents IV, we're giving this via the lung. So essentially what happens is that we measure the partial pressure of the anesthetic agents, and you'll see this in the gas analyzers via the percentage, right? So what we target, we measure the partial pressure in the lung, which is a marker eventually when it equilibrates of the partial pressure in the brain. Now, the anesthesiologist must be cognizant of the different things that could affect this uptake of this inhalation agents, and there's a list of things there that you could look at, but the anesthesiologist must know what are these factors. Now, one of the things you have to know with regards to this is the MAC, the concept of MAC. So one MAC, right, pay close attention to the definition now, is the percentage concentration of a volatile agent in the carrier gas that will upturn physical movement in response to a surgical stimulus in 50% of unpremedicated and unparalyzed patients. So if I give 1 MAC of an anesthetic to a patient, we can see that if this 1 MAC will prevent movement in 50% of patients. Now, you might say, well, doctor saying, what happens to the other 50% of patients that may move? Well, right, that's why we usually give more than 1 MAC, 1.2 MAC. But a point to note is that there are a lot of other factors that could affect the MAC and, in a sense, reduce the MAC. So these are some of the factors here. Things we have to take into account are the age of the patient. For example, the comorbidities of the patient. Is the patient an alcoholic user? Is it acute? Is it chronic? What about electrolytes abnormality? So a lot of things affect MAC, but that definition is important that you need to do. So MAC prevents movement from surgical stimulus in only 50% of patients, right? So these are some physical properties of the anesthetic agents. Now, on to the pharmacodynamics. So this is another important section. So pharmacodynamics is just really how the drug affects the patient. So we're going to go through it systematically. So the first one is CVS. So all these anesthetic agents reduce the mean arterial blood pressure and your cardiac output in a dose-dependent manner. And the main mechanism how they do that is by dropping your SVR. They vasodilate you, and your mean arterial pressure falls. They also arrhythmogenic. Newer agents less so. So these inhalation agents have a significant effect on somebody's cardiovascular system. So these are summary slide here with all the cardiovascular effects, and you can compare the different agents. You don't need to go into too much detail on the different agents. It suffices to say that it reduces the cardiac output, your SVR, and it drops your blood pressure. Respiratory. Now, all these agents, inhaled agents, that is, depress your ventilation. Your tidal volume decreases and your respiratory rate increases. Now, the point to note is that the IV agent causes apnea. These generally just cause respiratory depression. Another important point is that some of these agents have an effect or a direct effect on the airway tone. So some of them, for example, isoflurane is very irritant to the airway, and it could worsen the patient's airway pathology if the patient is asthmatic, whereas sevoflurane is non-irritant and can actually cause bronchodilation. No, CNS. Well, the obvious CNS effect of the anesthetic agents are anesthesia. It also decreases your oxygen consumption, but it increases the cerebral blood flow and it increases the ICP. Now, the renal effects, very little renal effects. There's a theoretical effect of sevoflurane causing renal failure when there is production of substance E. But this really has not been found in a lot of trials, and these agents are generally safe to use with no renal effect. Now, GIT, all anesthetic agents, all volatile anesthetic agents are associated with nausea and vomiting. That's why it's common after anesthetics. But with the advent of modern anesthesia techniques and antiemetics, like, for example, granisetron, ondansetron, the incidence of nausea and vomiting has been significantly reduced. Older agents like halothane used to cause serious complication in hepatic failure. Now, you may see a lot of people using nitrous oxide. Now, nitrous oxide is a second gas that is used, and nitrous oxide is an adjuvant to general anesthesia. The reason is that nitrous oxide cannot provide an anesthesia on its own because its MAC is too high. The MAC is probably more than that would be safe to give a patient because you wouldn't be able to administer any oxygen. So it provides anesthesia at low dose, analgesia, sorry, at low doses and loss of consciousness at higher doses. There's a slight depression in the respiratory system and really minimal effect on the cardiovascular function on its own. Problems with nitrous oxide is that it causes nausea and vomiting, and with patients with pneumothoraces and all these sorts of things like that, nitrous could cause it to expand. It also causes bone marrow suppression and a peripheral